Hi, this is Denise with HealingHacker.com, and today I'm talking with Dr. Stephen Miller of Northwestern University Medical School. And Dr. Miller was part of a team of scientists that essentially took, in mouse models, took a peanut allergic mouse or peanut allergic mice that were previously anaphylactic to peanut and made them non-allergic. And so I'm hoping that Dr. Miller can shed some light on that study. And thank you for talking with me today, Dr. Miller.
Oh, no problem. Happy to do it.
So I'm going to let you jump in and talk about your study. And I'm going to just say the title, which is, it's called Antigen-Fixed Leukocytes Tolerize Th2 Responses in the Mouse Model of Allergy.
Right. So my lab for many years has been focused on developing what immunologists call tolerance-based therapies for immune-mediated diseases. And the primary focus of my lab for many years has been in animal models of multiple sclerosis and type 1 diabetes. The study you're referring to, we initiated about 4 years ago in collaboration with Dr. Paul Bryce at Northwestern, who's an expert on allergy and animal models of allergic disease. So what we tried to do when we set out to begin the study was to ask, the methodology that we developed that was successful in inducing tolerance for the therapy of autoimmune diseases, could we do that also in models of allergic disease? And so the study involved taking leukocytes from mice and using a chemical reagent to attach peanut antigens to those leukocytes, and then to administer those leukocytes by intravenous infusion into mice, either prior to the induction of food allergy, but more importantly and more clinically relevant, to administer those to mice who already had ongoing food allergy and were anaphylactic. And the idea of the therapy is to expose the mice to antigen in such a way that it induces, that it turns off the immune response rather than activating. So basically what we showed in the study you referred to was that if we use the cells from the particular strain of mice, attached peanut antigens, and we've done it with egg antigens also, to those leukocytes and administered those to mice that had ongoing disease, we could actually protect them from the induction of an anaphylactic challenge by feeding the peanut extract to the mice, via oral infusion. Now, I should point out that this methodology was actually successfully used in a phase 1 clinical trial in multiple sclerosis patients that have an autoimmune disease, not food allergy. But regardless, what the study showed that it was safe to take human leukocytes from the blood and attach, in the case of MS, we used brain antigens, and manufactured those in blood bags and then reinfused them back into the patients. And we showed that it was safe to do this, and more importantly, that we could diminish some of the autoimmune responses that the patient had prior to the therapy when they were retested 1 to 3 months after the therapy. Now, so the question is, can we use a similar methodology to develop a safe and effective therapy for food allergy? So autoimmune disease and allergy are sort of on opposite ends of the pole. Autoimmune diseases are mediated by certain distinct types of T cells that cause damage to self tissues. Like MS is an attack against the brain, type 1 diabetes an attack against pancreatic beta cells, rheumatoid arthritis an attack against joint proteins. Whereas allergies are mediated by a totally distinct subset of T lymphocytes that talk to other cells that cause the production of IgE, which probably everybody's heard of, which is the anaphylactic antibody. So what these studies combined prove is that the tolerance strategy that we're using, it has proven, at least in preclinical studies in animal models, to be effective not only for the prevention, but more importantly for the treatment of both autoimmune disease and allergic disease, both of which are immune-mediated disease processes. Now, I should point out that since the paper was published that we're talking about in the food allergy, we've developed a new strategy to induce tolerance in humans, which instead of using the patient's own blood cells to attach either the autoimmune antigens or the allergic antigens to induce tolerance or turn off the immune response, we now find that we can do this using manufactured, what we call nanoparticles, that are actually composed of an FDA-approved polymer called PLG. Just to give you some concept of this, PLG is what resorbable sutures are made out of. So if you have an operation and you have your kidney operated on, and they stitch up their kidney, you can't do it with regular silk sutures, because they're going to be irritating and they're going to actually cause an immune response. So so internal sutures are actually made of a substance called of a nanosubstance that's actually biodegradable. So after a period of time, these sutures will simply dissolve and go away. So we've developed methodology where we can make this PLG material into small microspheres. They're actually nanoparticles, about 1/20th the diameter of a human hair, and we can either attach the autoantigens or the allergic antigens onto the surface of these nanoparticles, or actually encapsulate the antigen inside these nanoparticles. And we find we get the same or even, in most cases, a better induction of tolerance. And
Wow.
the advantage of this is that now we have a lot of interest from large biopharmas to partner with us in trying to develop this as therapies for these diseases, where they were very reluctant to go down the road of using the cellular therapy because of the cost and complexity involved in that. So, we've formed a company now, and our goal of the company is to get FDA approval to carry out early clinical trials, hopefully in both autoimmunity and in food allergy, to look at the safety and preliminary efficacy of treating those two types of diseases using tolerance-based strategies.
So when you say tolerance, can you explain the difference between tolerance and desensitization? Because I think that's a really important distinction.
Correct. So the current therapies for allergy, and please remember, I'm a basic immunologist. I'm a mouse doctor. I'm not a physician who treats either patients with autoimmunity or allergy. So I'm telling you what I understand. So some of it may not be totally correct, but the current therapies for allergy involve repeated administration of low doses of the antigen that you're allergic to, either ragweed pollen or peanut extract or egg extract, whatever. And the purpose of that is to induce a particular kind of immune response that will absorb to these antigens and prevent them from engaging IgE in the allergic individual. So we call that desensitization because, as a matter of fact, what you're doing is you're shifting the immune response from one kind to the opposite kind, the kind that doesn't cause allergy, in order to sop up the antigen, the allergen, and keep it from triggering the clinical signs of anaphylaxis and allergy. Now, what we're doing is called immune tolerance. So what we found, our therapy, instead of switching the immune response from an allergic kind to a non-allergic kind, we actually take the allergic and shut it off. So it's a much more desirable way to go about it, because the tolerance that we induce is mediated by particular kinds of cells called regulatory cells, which essentially will maintain the ability of the individual not to respond to the antigen you tolerate to for a very long period of time. In mice, it's essentially for the lifetime. We don't know how long it lasts in humans until we actually do that in a clinical trial and figure it out. So there are multiple advantages. We think it's safer, that we can administer our antigen-coupled cells or nanoparticles in individuals who already are allergic and are carrying IgE antibodies safely. And the net result of that is we shut down the T cells called Th2 cells that are the helper cells that help the IgE antibody to be produced. So that's the difference.
You know, talking about IgE, something that, and again, I read the study, and I'm not a scientist, I'm not a doctor, so correct me if I'm wrong, but in the study, my understanding was that you noticed in the mice that were treated, you know, with your treatment, like you're talking about, they actually had higher IgE levels than the mice that were not treated. So how do you explain that?
Yeah, so that's an interesting phenomenon. We've seen the same phenomena if we substitute the nanoparticles for the cellular therapy that was described in the paper that you read. So the way this works, in order to get, so despite the fact that we had an increase in the amount of IgE antibody in the mice that we treated, they were still protected from the anaphylactic response. And, you know, the reasons are complex and we don't understand them totally. But the reason is that we actually induced regulatory cells, these special types of lymphocytes called T regulatory cells, that actually prevent the mast cells from liberating the mediators like histamine and serotonin and the other anaphylactic mediators. Now, you have to remember that our tolerance therapy, we have two cells that are involved in making IgE. We have Th2 cells that talk to other lymphocytes. I don't want to get too complex here. Called B cells that actually are the ones that become plasma cells that actually squirt out the IgE. So our therapy is directed toward lowering the activation or the effector function of these T cells. So we're in a patient or an animal that already has IgE, we wouldn't expect to affect, at least in the short term, the levels of IgE, because this antibody has a half-life of several months before it decays away. But we can knock out the helper cells that are required to continue to talk to these B cells to continue to make antibody. So in the short term, we're protecting the animals against the anaphylactic challenge because part of what we're doing is inducing regulatory cells in addition to knocking down the Th2 helper cells. Now, if we would wait in these animals for a longer period of time, our expectation is, and this is yet to be proven, is that the allergic antibody would eventually decay away because the T cell help that's needed to maintain it, we've downregulated and hit. Right? The other way we're thinking about treating allergies, including food allergy, is to combine our tolerance therapy, which is going to knock down the helper cells, increase the regulatory cells, but also to use another therapy that's being tested in clinical trials in allergic patients, which is using an antibody to IgE to try to absorb the IgE to keep it from participating in the release of mediators from mast cells. So we would propose that the most effective short-term treatment that would have long-term protective effects would be to combine our tolerance therapy to knock out the helper cells, but also to use an anti-IgE to sop up the IgE that the person already has circulating in their bloodstream and attach to their mast cells and basophils. And that would have an immediate effect of protecting them, but in the long term, the induction of the tolerance would maintain that tolerance over a long period of time, hopefully months to years.
Got it. And so, and I'm just curious, like what sort of, because you're talking about the combo therapy with the anti-IgE, what sort of side effects have you noticed? Like what kind of, in the MS study that was done with humans, what sort of side effects, long-term, medium-term side effects did the treatment have?
That was the, the primary outcome measure of a phase 1 clinical trial is safety. And by administering up to several billion cells that we collected from the peripheral blood of these patients and then put through this blood bag process to attach, in that case, brain antigens onto the surface of them, and then re-administering those cells back into the same patient. We call that autologous cell therapy, right? Because we're using the patient's own cells, manipulating them, and then reintroducing them back into the same patient. So that's called autologous. We saw, believe it or not, no significant side effects at all from that process. I can't tell you about the nanoparticles, which we think is the future of the way to go, because we haven't tested those in humans yet. But all I can say is in mice, we never observe any untoward effects of those particles. And we can treat animals multiple times if we want to. We don't need to because the therapy actually lasts for a very long period of time, as I mentioned before.
So this was a mouse model of food allergy, and the MS model that you're talking about, the MS study was in humans, but for the mouse model of food allergy, is there anything that you haven't discussed as far as what does that mean in human models?
Yeah, well, that's always hard. We scientists, we always have this argument. If you're modeling disease in a mouse model or in a dog model or a chimp model or whatever, the model is what its name implies. It's a model. It's not really the disease. But, you really have to run these models to ask whether what you're trying to do is safe and efficacious. And the FDA is going to require that before we can even hope to get permission to try a therapy in humans. So you do your best to use the most efficient animal models that you can use that most closely mimic the human disease condition, but you never know whether it really is going to do that. And to be brutally honest, there are a lot of things that work in mouse models that don't work in humans, and that's why we have to do clinical trials to find that out. So
yeah,
we're encouraged by the robustness and the specificity and the lack of side effects that we see in the animal models. We hope the same thing repeats itself in humans, but we're never going to know that until we try.
Fair enough. Let me ask you another question. So this is really about peanut allergy, or as you mentioned, egg allergy, and even in MS, you were taking brain antigens. So this is one specific allergy, one specific antibody.
Right.
What can we learn from these studies in the multiple food allergy sort of a spectrum? Is there anything that anything we can glean in that multiple?
That's a good question. So our approach would be that if somebody has peanut allergy, we would want to hit the T cells that are recognizing peanut antigens and shut those down, get rid of them. So if somebody was allergic to multiple foods, that, and as I understand it, some people are allergic to multiple, perhaps shellfish and egg and peanut all. You would have to make these nanoparticles or couple these cells with each individual antigen. So that's the strength, and I guess maybe you would say the weakness of our therapy. The strength is we're highly specific. If we put peanut antigen into the individual, we're only going to knock down their peanut antigen allergic response. We're not going to affect the egg antigen response if they're allergic to both. To affect the egg antigen response, we'd also have to treat them again or at the same time with a combination of different antigens. So we know, at least in the autoimmune models, the MS models in mice, that we can actually put multiple antigens onto or into these particles, each one of which will induce this animal model of multiple sclerosis, the paralytic disease. And if we put nanoparticles in with 2 or 3 antigens, we can protect them from disease induced by any one of those antigens that's on board. So you could imagine a situation that somebody had multiple allergies and this proved to be safe and effective, that they would be eventually treated with nanoparticles that are expressing each one of the allergic food substances that is responsible for their particular disease.
Got it. So, and I'm just curious, with what can we learn from these studies as far as like what are the greater concepts that you're learning about allergy, atopy, autoimmune disease? Is there anything that we can learn from your studies about how those things function, kind of like a higher level vision?
No, absolutely. One of the questions of both the autoimmune and allergic disease is, why are some individuals susceptible to developing those diseases and other people are not? And we think, there are, I'm going to give you one example, which is there's some sort of deficiency in regulatory T cells in an MS patient that somehow makes them more susceptible to developing the autoimmune disease, or into a peanut allergic individual that they have some kind of deficit in their in this regulatory immune response that keeps most of us from getting autoimmunity or allergy. So there are multiple reasons. There are genetic reasons why people are more predisposed to getting these diseases. There are environmental components. In allergy, we know the environmental component. It's somehow ingesting that food stuff, whatever it happens to be. In autoimmune disease, we know that there's a genetic predisposition, but we also know there's an environmental component there. The only trouble is we have no idea what that environmental component is. People think it's people with particular genetic types that get infected with something at a certain period in their life that somehow interferes with what we call self-tolerance or the activity of these regulatory cells. By studying both of these models, we've come to understand how regulatory cells are induced and operate. We've come to learn a lot more about the intricacies of how that happens, so that sometime that may lead to more effective and simpler ways to, in an allergic individual, you want to increase the regulatory cells to stop the amount of immune response. The same as in patients with autoimmunity, you'd want to increase the regulatory cells relative to the autoreactive cells. Now in cancer, you would want to do the opposite. The person's not making an effective immune response to clear a tumor, so you would want to lower the regulatory cells and increase the effector cells. So by learning how tolerance works as an entity by itself, not really specific to any particular disease, we're going to gain a much better understanding of how to manipulate the immune response to either enhance it in terms of cancer or to lower it in terms of treatment of autoimmunity and allergy.
Wow. That's very interesting to think about, because the regulatory arm seems so important in all of it.
Regulatory arm is absolutely critical. Both arms are critical.
Yeah.
And when you have one of these diseases, things are out of balance for some reason or another. And so that's really important to understand why and how we can overcome that.
Yeah. One final question that just came to mind. I'm just curious, when you're delivering these antigens intravenously, what's the difference of getting them that way as opposed to consuming them? Why does delivering them that way induce tolerance, but consuming them doesn't?
Yeah, that's a great question. And we understand a little bit about that. So what we've learned is that when we intravenously infuse these antigens, they actually, that are either attached to the cells in the therapy that of the paper that we're discussing, or onto the nanoparticles, they pretty much work the same way. They actually direct that antigen to certain phagocytes that are in our spleen and liver, that once they eat up the cells decorated with the antigens or the nanoparticles decorated with the antigens, they talk to the immune system in such a way as they turn down the immune response rather than turning up. And the analogy I always give is the following. So our immune system is important, obviously. It evolved to protect us against infectious diseases, right? Allergy and autoimmunity are just a bad side effect of a system that evolved to protect us from viruses, bacteria, fungus, infections, and so forth, right? So, the immune system also deals with a lot of cells that die as a normal course of our physiology. So I'll give you a particular example. Red blood cells, we have literally, billions of them per cubic ml of blood. But those red cells have a very short half-life. They age and die, what we call senescence, with a average time span of probably a couple of weeks. So the immune system is constantly seeing red blood cells and white cells that are dying as a normal consequence of, how they're produced and how they function. But, the immune system has evolved ways to maintain tolerance against self. The last thing we want to do is respond against dying white blood cells or red cells. And there are autoimmune diseases that actually that attack our own red cells and white cells. And just about any other cell in our body is the target of some or another autoimmune disease. There are hundreds of them. So the immune system many millions of years ago evolved a way to eat up normally dying cells in such a way that it wouldn't alert our immune system that it's something to be worried about, something that we have to make a response against, right? And those cells that are responsible for the uptake and disposal of senescing red cells and neutrophils and other leukocytes in our circulatory system are these cells that sit in the spleen and liver, right? And because of the way that we produce these nanoparticles, when we inject those intravenously, they are uptaken by those exact same cells, which then talk to the immune system in such a way as they turn off the response rather than turning it on. Is that clear?
I think so. Sorry, go ahead.
We're actually going into a system that into a procedure that the immune system was smart enough to have evolved millions of years ago to protect us from responding against our own blood cell components. And we're artificially targeting those same cells for the treatment of autoimmune diseases, which can either be in the brain or in the pancreas, or allergic diseases, which can be taking place in the lung or in the gut or whatever.
I think I get it, and I'm just going to rephrase it back to you quickly. Okay. In an analogy, it's almost like if you sneak into a restaurant through the back door and you put on a waiter's uniform and go into the restaurant, you're accepted, as opposed to you come in the front door and you're dressed in a way that isn't appropriate and you're rejected.
Exactly. Come in with a gun and a mask.
Yeah, exactly. Okay. Right. I think exactly. That makes sense.
So we have to get rid of dead and dying cells all the time. That's hopefully that's done in a non-stimulatory, non-immunogenic fashion. And for most of us, it is. For people with autoimmune disease or allergy, something has gone awry with that process. And they're now making immune responses against our own cells or proteins or something that we eat, right? And we don't want that to happen. So we're going back and using what the immune system was smart enough to have evolved over millions of years to deal with that kind of process. and we're using it to reestablish tolerance to either the autoantigens or to the foodstuffs we're eating.
Got it. Wow. Well, I really appreciate your talking with me this afternoon. Is there anything else that I've missed that you feel is important for us to think about or to know?
No, I think that's the gist of it. So, where we go from here is, we formed a company based on this methodology of using these nanoparticles, and we're talking to a number of larger biopharmas to try to get them interested in to invest in our technology. And we're trying to develop this for the treatment of, autoimmune diseases and allergies. The beautiful thing about the methodology, it's actually can be used to both simply by changing an antigen from a brain antigen on the nanoparticles that we'll use to treat MS to peanut antigens or a peanut extract. We can treat multiple sclerosis on one hand, or hopefully food allergies on the other hand, using an FDA-approved, biopolymer that what we call the universal tolerogenic carrier. So this has potentially far-reaching implications, but we're not going to get anywhere until we get investment to test this out in human disease.
Sure, sure. All right. Well, thank you so much, Dr. Miller. And I hope that you keep us abreast of how things proceed with the nanoparticle study. And
yeah, happy to. We can talk again sometime.
Yeah, that would be great.
Okay.
All right. Thank you so much.
Bye-bye.
Bye.